Hello, a good day to everyone. My name is C.D. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome you all to today's Research in Progress webinar series on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We have a great topic for us today from one of our new cohort of grantees on their research on integrating health and social services for veterans by empowering family caregivers. Before we get started, though, I'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. Systems for Action is a national research program of the Robert Wood Johnson Foundation and a collaborative effort with the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics here at the University of Kentucky. And today's presentation, the slides and audios for today's webinar, like all our webinars, will be available for download from our Systems for Action website. Also, I'd like to encourage everyone that at any time during today's presentation, please type in your questions in the chat box located in the lower left-hand corner of your screen, and we will try to get to them later during the Q&A portion of this webinar. So without further delay, it is my pleasure to introduce to you today's webinar presenter and commentator. Our presenter for today is Dr. Megan Shepherd-Bannigan. Megan received her PhD in Health Services Research from the University of Washington in Seattle and recently completed a postdoctoral fellowship at the Durham VA HSR&D. Megan currently is an investigator at the Durham VA HSR&D and an assistant professor at the Duke School of Medicine's Department of Population Health Sciences. Megan specializes in mental health services research and family systems approaches, improving health, social, and economic contextual factors. Our commentator for today's webinar is Jennifer Henius, is a licensed clinical social worker with nearly 15 years of service at the VA and has served in a variety of clinical and administrative positions. Jennifer completed her master's degree in social work at the University of South Florida and is an alumnus of VA's Graduate Healthcare Administration's training program, which serves to develop high-performing leaders for career in healthcare administration. Jennifer serves as a senior health systems specialist for the VA's Caregiver Support Program Office and provides high level of staff work in support of the National Director in implementing and the oversight of the Caregivers and Veterans Omnibus Health Services Act of 2010. She's also had the lead for drafting the program's published national policy guidance and is responsible for the Secretary's annual report to Congress. And Jennifer also serves as the program lead for the collaborative partnership with VA Cares and has served in an integral role in its inception. So without any further ado, I first turn it over to you, Megan.
Great, thanks, CV. And thanks everyone for being here with us. I'd also like to start by thanking the Robert Wood Johnson Foundation for their support and the team at the University of Kentucky for everything they've done to support our efforts. So I'm going to be presenting some of our preliminary results from our project titled Integrating Health and Social Services for Veterans by Empowering Family Caregivers. This is a one-year individual project, and so we are just over halfway through. I'd also like to acknowledge our team at the VA HSR&D in Durham, and then also our partners in the VA National Caregiver Support Program. So I'll start by giving a brief overview. We'll first talk about the context and the problem, a potential strategy to address that problem, the research questions that came out of having this potential strategy and the approach that we use to address those research questions. And then I'll discuss preliminary results from one of our outcomes, and then we'll talk about next steps. So within VA, the most important actor is always the veteran. 3.3 million troops have been deployed since 2001. And due to advances in battlefield medicine that made previous injuries that were previously fatal not fatal, there are a lot of troops returning with substantial cognitive, physical, and emotional disabilities. It's estimated that 14% of returning troops have a PTSD diagnosis, and 19% have a traumatic brain injury diagnosis. So comorbidities such as these may cause some veterans to experience challenges reintegrating back into civilian society. Challenges could include maintaining social relationships, employment, and education, economic vulnerability, and consequent declines in health. So we've got a veteran with cross-cutting medical, social, and economic needs. And then here within VA, we also have multiple administrations that offer services to directly address some of those needs. First, we've got the Veteran Health Administration, or the VHA, that offers evidence-based medical and psychological services, including therapies for TBI, PTSD, spine injuries, and amputation. We also have supported employment, which helps individuals with disabilities to find and maintain competitive community-based employment. While supported employment was originally developed for individuals with serious mental illness, within VA it's been adapted for folks with TBI and PTSD. Research shows that supported employment is associated with competitive work attainment, longer job tenure, higher income, and increased days of paid employment. We also have the Veteran Benefits Administration, or VBA. VBA offers education assistance, including tuition, housing, and funds for school supplies through the post-9/11 GI Bill, which was established in August 2009. Vocational rehab offers career guidance, services to seek jobs, including interview prep and resume prep, and also education assistance with the goal of securing employment. While there's minimal research right now on the post-9/11 GI Bill, this research does suggest that having access to post-9/11 GI Bill benefits drives veteran decisions to pursue higher education. Furthermore, some studies about the pre-9/11 GI Bill suggest that among Vietnam-era veterans, VA education assistance was related to a modest increase in funding. Due to the difficulty in gaining access to VBA data and to linking it to VHA data, though, few people have had the opportunity to examine the impacts of voc rehab and the GI Bill on longer-term veteran outcomes. So you would assume that with, we've got two systems that address both health and social needs, that there would naturally be coordination. However, this really isn't the case. The delivery of all of these services is compartmentalized within distinct VA bureaus across different program offices, and they utilize different data systems. This impedes coordinated approaches to integrated care. Lack of needed medical, psychological, and social services can inhibit veteran recovery and lead to long-term financial, social, and health consequences, including suicide. So we propose that the family caregiver could be an important mechanism to link veterans with both VHA and VBA benefits. And specifically within VA, we've got, or VHA, we've got institutional support for caregivers. We hypothesize that a cadre of trained, knowledgeable, and engaged family caregivers has the potential to activate key drivers of health and social system integration, including increasing access to care, improving integration across systems, and improving consumer experiences. In fact, some of the research that we've done here at the Durham VA suggests that support for caregivers can increase veteran use of outpatient services. However, currently no data exists to understand the role that caregivers play in connecting veterans to social services, and we haven't really done a lot of, there's not a lot of research that looks to understand the mechanisms underlying support for caregivers and some of these outcomes. So in essence, we're proposing that when you have institutional support for family caregivers can actually serve as a cross-sector alignment mechanism. So within VA, we've got multiple opportunities to examine this issue. In 2010, Congress passed the Caregiver and Veteran Omnibus Health Services Act that outlined specific new services for caregivers of veterans. It outlined two programs. One is the program of general caregiver support for caregivers of all veterans in need of a caregiver. Secondly, it outlined the program of comprehensive assistance for family caregivers that we'll now refer to as PCAFC. This targets caregivers of eligible veterans who were injured in the line of duty on or after September 11, 2011. So these are veterans who by and large served in Afghanistan and Iraq. And it's this second program that we are sort of deeming to be the VA's institutional support for caregivers, and that's the focus of this research. Both of these programs are housed in the VA Caregiver Support Program Office in the VHA under the Care Management and Social Work Services Patient Care Services. So just a really quick overview about PCAFC. It is a clinical program. As I mentioned, it's housed in VHA, and it provides services directly to eligible caregivers. The PCAFC is also meant to support veteran recovery and reintegration. That's a key goal of this program. The program offers caregiver training and education, a monthly stipend, access to caregiver support coordinators that serve as touch points for caregivers within the healthcare system, health insurance, mental health services, respite care, travel reimbursement to accompany veterans to doctor's appointments, and then building better caregivers in the caregiver support line are training programs, and they offer the caregiver support line is basically a telephone-based line that caregivers can call. I'd like to acknowledge that several of these services are also available for caregivers in the general program. What's specific to PCAFC is a mandatory caregiver training, the monthly stipend, mental health services, and health insurance are sort of the key components of PCAFC. The total number of participants since the program started in 2011 is about 40,000. And to date, over $2 billion of PCAFC stipends have been paid to participating caregivers, and that the yearly budget is over $500 million. So this is a really big deal. It's a big deal within the U.S. health system. There is no other support for caregivers. This support is unparalleled in the U.S. health system. So we're really proud of VA. Furthermore, this program was expanded in May of this year and extends PCAFC to caregivers of veterans of all eras, and it'll start by expanding PCAFC services to caregivers of veterans who served in Vietnam or earlier. So we've got the problem, and we've got a complex health and social needs among veterans. We've got a potential strategy, which is family caregivers. Within VA, we've got opportunities to study this, including institutional support for family caregivers and data integration. And so this led to two of our research questions. The first research question, AIM 1, is a quantitative aim and asks, can institutional support for family caregivers through PCAFC impact the use of social services? And we're specifically interested in education assistance and vocational rehabilitation. The second aim is qualitative and asks, what features of family caregiver support facilitate alignment of health, psychological, and social service delivery systems to meet veteran physical, mental, and social needs? So I'll begin by giving an overview of our AIM 1 approach. So essentially, we're interested in whether participating or being approved for participation in PCAFC impacts time to use of 3 supported services. And the services that we're looking at are the post-9/11 GI Bill benefit, voc rehab through VBA, and supported employment, which is a type of vocational rehabilitation, but that is offered through VHA. With support from our partners in the Caregiver Support Program, we were able to gain access to Caregiver Support Program administrative data and VBA administrative data. And then we linked that to VHA electronic health records and administrative data. Our samples includes veterans whose caregivers applied to PCAFC between May 1st, 2010 and September 30th, 2014, and did not use social services prior to had not used the specific social service prior to their application for PCAFC. So in essence, we've got 3 cohorts. We've got 1 cohort for each of our social service outcomes of interest. The control group is caregivers who applied to PCAFC but were never approved to enroll in the program. As we're doing a time to use analysis, we're using Cox proportional hazards regression models, and we are also using an instrumental variable. The treatment variable ever having been approved for PCAFC, the outcome variable of time to application for the 3 services, post-9/11 GI Bill benefit, supported employment, and voc rehab. Our instrumental variable is the facility level percentage approval for PCAFC in the 6 months prior to that DIAD's application. As the PCAFC is already up and running, we were clearly unable to randomize individuals to PCAFC versus no PCAFC. And we assume that there's a non-random selection both into PCAFC and into social service use. For example, individuals who are accepted into PCAFC may have unobserved characteristics that also affect their desire or their just general use of social services. For example, personal expectations for engaging in work and school may be related to health. If someone is sicker, they may be more likely to be accepted to PCAFC, but they also may have lower personal expectations for their ability to pursue services offered through the post-9/11 GI Bill benefit. So by using the IV, we're effectively able to pseudo-randomize or sort individuals such that their characteristics are balanced across treatment groups. An IV is a variable that's only related to the outcome through the treatment variable. To be justified, the IV must be strongly related to treatment, which is IV strength, and it must not be related to the outcome except through treatment, which is the IV validity assumption. I'd like to point out we used a new IV method developed for Cox proportional hazard models that was developed by Dr. Cambler-Martinez, and you can look that up in his 2018 paper. This applies a 2-stage residual inclusion approach and adds a frailty term in the 2nd stage equation. And the purpose of that is to control for any association that can be induced with the treatment due to the fact that you're conditioning on covariates and survival status in the period prior to the instantaneous hazard rate. Oh, here we go. Okay. So the approach for AIM-2, as I mentioned, is qualitative and asks what features of family caregiver support facilitate the use of social and medical services. We are in the process of conducting 25 to 30 in-depth telephone-based interviews. Caregivers and veterans are participating together in these interviews. Our sample comprises all individuals who enrolled in PCAFC and used one of the 3 social services, so voc rehab, the post-9/11 GI Bill, or supported employment. We've actually started analysis on our first 22 interviews using a priori themes and then identifying emergent themes as they appear. To date, we've completed 22 interviews and we've analyzed 6 transcripts, and the dyad is the unit of analysis. So this shows the sampling frame and the process for our AIM-2. Our full sampling frame included about over 1,700 veterans. And then I'd like to direct your attention to the 3 boxes that are immediately below that large gray one at the top. That shows the full potential sample of people who could potentially be contacted for the interviews. We had over 750 for the GI Bill, over 900 for voc rehab, and about 200 for supported employment. Right now we've completed 11 interviews for those who use the GI Bill, 10 for those who use voc rehab, and 5 for those who use supported employment. I'd like to these numbers are actually not mutually exclusive because many veterans use more than one service, so that's why those don't add up to 22. I'd also like to acknowledge that we've had a really difficult time recruiting folks for supported employment. Originally we wanted to get 10 interviews for each of these services, but we're probably we've contacted almost everyone possible for supported employment, so we may not get any more, but we're still working to a couple more people. Okay, so now I'm going to present the preliminary results for the quantitative AIM-1, and please note that I'm only going to focus on the results for the post-9/11 GI Bill benefit use. So here's our table 1. You can see in red that's the sample for the post-9/11 GI Bill cohort. We've got over 11,000. 6,400 were approved for PCAFC, and about 4,600 were never approved for PCAFC. About 13% of veterans across the groups use the post 9/11 GI Bill. You can see this is a pretty young cohort. Folks are in their mid to early 40s. The caregiver is overwhelmingly the spouse of the veteran. And then service connection refers to the percent disability that a veteran gets for a disability related to having served in the military. And so you can see that a lot of these folks have a very high service-connected disability rating. It's higher than 70% for over half. So that indicates that folks in our sample have a lot of comorbidities, and they're pretty sick. So the results of the first stage, we looked at the IV strength, and you can look at how strongly related the IV is to your treatment by doing an F test of the IV variable in the first stage equation. An F statistic that's greater than 10 is considered to be sufficiently strong. Our F statistic was 14. IV validity is an untestable assumption. What we sometimes do is we compare the balance of observed covariates across levels of the treatment versus levels of the IV. Improved balance across levels of the IV could indicate that unobserved confounding would also be improved by the IV. However, we can't test that for sure. So this table shows balance by key comorbidities across whether a veteran was approved or denied from PCAFC. All of the variables that are bolded show that there was a standardized difference greater than 10 for that variable between being in the approved and the denied group. So you can see there's quite a lot of imbalance in comorbidities across approved and denied for PCAFC, which is what we would expect. This table shows balance by the IV. And so the only two variables that had a standardized difference greater than 10 across levels of the IV, and we did the median, was joint pain and post-traumatic stress disorder. However, in both of these cases, the standardized difference was less than 12. So we were pretty happy with that balance. Here are the results. We compared the naive adjusted Cox proportional hazards model, so this is the model that didn't include the IV, to one that did include the IV residual and the frailty. The point estimates are pretty similar. Models were adjusted, I should say, for health comorbidities, demographics, distance to the nearest facility, caregiver-veteran relationship, VA level disability and insurance variables, service use, facility fixed effects, and application time period fixed effects. So really we're not seeing much of anything going on here. Both of these models are suggesting that being in PCAFC or having been approved for PCAFC is not strongly related to use of the post 9/11 GI Bill. Okay, now I'm going to go on to sharing some preliminary results from AIM-2. Again, we focused on just a couple transcripts of folks who used the post 9/11 GI Bill. So we randomly selected 6 transcripts among the 11 of individuals who only used the post 9/11 GI Bill. In all of these interviews, the caregiver was the veteran's spouse. We had 4 individuals who were still actively in PCAFC and 2 who had transitioned out of the program. And the age of the veteran is mid-30s to early 40s, so again, a young cohort. So one of the really clear emerging themes is that veterans used the GI Bill to integrate back into civilian life. They used it to help with their reintegration. One caregiver said having the GI Bill helps him to figure out another path for his future and reinvent himself. Both veterans and caregivers also recognize the direct link between addressing social needs and health. And by social needs, we mean relationships, school, work, sense of self. One veteran who had pursued a degree and actually completed a degree in sports education said that sports has become a really huge factor in my recovery, not only sobering up, but redefining not only who I am, but who I want to be. I figured what better way to be who I want to be than educating the next generation in the pros and cons of what sports has to offer. We asked all veterans what their life goals were, and for the large majority, life goals included both social and medical needs. So some of the social goals include focusing on a career, getting an education, having children, taking care of their family, building relationships with loved ones. Medical goals included reaching sobriety, controlling anxiety and PTSD, focusing on physical health issues such as a back injury, finding employment that was realistic considering some of the physical and psychological needs that the veterans had. We saw that caregivers were a critical facilitator of engaging in medical care and in the post-9/11 GI Bill. We were actually able to identify similar typologies of caregiver functions across both services. So we were able to sort of classify caregiver functions into logistical, emotional, and advocacy. So right now I'll just focus on the role that caregivers play in helping the veteran with their medical care. And these include, so in this box, the N equals is the number of individuals who responded affirmatively or told us about this. So that's what those numbers mean. So 4 caregivers said that they managed appointments and medical records. Over half managed medications, and 4 said they reported attending appointments with the veterans. Emotional tasks include remaining engaged to help address the veterans' frustrations with their medical care. Another couple of caregivers said that they would ask providers for additional services and help, and most of them communicated with the providers. One caregiver said, I try to make sure he's seeing who he needs to be seeing and for issues. I like to make sure he's following up with one of his providers that can help him out in that aspect, whatever he's having an issue with. But they've got a lot of bumps in the road when it comes to his medical history and everything with depression. And sometimes he looks like he's going absolutely crazy. So I do try to stay engaged in medical areas. We felt that this quote reflected both emotional support and advocacy. Now moving on to tasks that the caregivers reported related to the post-9/11 GI Bill benefit. Many caregivers said that they helped the veteran to complete assignments and administrative academic tasks, such as enrolling in courses. Many acknowledged that they helped to manage the household to keep it a place where the veteran could be successful in school, and one reported driving the veteran to classes. Emotional support, they provided emotional support to help manage anxieties, uncertainty, and frustration for veterans who'd either never been to college or there were some veterans who talked about being in college with individuals who were a lot younger than them and really didn't understand military culture. And so caregivers provided a lot of support in this way. One caregiver said she spoke with instructors and then sought disability services as well. That caregiver said she ensured that professors were aware that he isn't a joke and he's here and he wants to be taken seriously. But it's more than just the arm that's missing. It's the intellectual and emotional disabilities that affect these veterans more because it's harder for us able bodies to recognize the difference. So from our in-depth interviews, it was clear that institutional support for caregivers through PCAFC was a critical facilitator for medical care. This role was a little less certain for the post-9/11 GI Bill, though we did identify some program features that participants said were very helpful. So regarding medical care, PCAFC staff provided, and the teams that do the eligibility home visits, provided referrals for veterans to go to health services and medical equipment. They provided disease education and caregiver skills education to caregivers, and they acknowledged the caregiver role. And both the caregivers and the veterans talked about how helpful this was. And this is not surprising because this is the role of PCAFC. This is the tasks that PCAFC staff are supposed to, this is what they're tasked to do. Related to the post 9/11 GI Bill, 3 participants said that the stipend was critical in helping them pursue the services offered through the post 9/11 GI Bill. One caregiver said the stipend was nice because it gave us time for the veteran to kind of figure out what he needs to do to get back on his feet. Like I said, he's trying to figure out what he was going to be after the military. It's been a couple of years, but it's been nice for him to have that along with the GI Bill to create a new career. Another veteran described how one of the nurses that came as part of the home visit, the PCAFC home visit, encouraged him to attend school and acknowledged that he was able to attend school and that this was very meaningful to him. So now just some preliminary conclusions from the full AIMS 1 and AIMS 2, or the mixed method study for this post 9/11 GI Bill. Veteran medical, psychological, and social needs are highly interconnected. Caregivers are critical facilitators of engaging in medical care, but also in the services offered by the post 9/11 GI Bill benefit. In our quantitative models, participation in PCAFC was not associated with time to application to the post 9/11 GI Bill, though our previous research, as I'd mentioned, shows that it plays a strong role in use of medical care. Despite this, from the qualitative interviews, we do see some early indications about some program features that could be effective in supporting engagement with the post 9/11 GI Bill benefit, specifically the stipend, information and resources about the GI Bill benefit, and encouragement from program staff. And we'll continue to explore a lot of these themes as we do our remaining analysis. So for us, next steps for the Quant AIM 1 is to complete the analysis for the voc rehab and supported employment outcomes. We're also interested in examining all 3 outcomes in a subset of younger veterans. We acknowledge that younger veterans are more likely to see value in seeking both education and voc rehab assistance, particularly for those in their 30s and 40s. So we'll examine the outcomes in a younger subset. For AIM 2, we plan to complete the qualitative analysis of the remaining 18 transcripts that we have. We do have 1 interview scheduled, and we plan to conduct another 3 to 8 interviews that target any gaps that we identify from the ongoing qualitative analysis that we're doing. Finally, we'll prepare recommendations to share with partners and have some plans for papers and posters in a variety of venues, including social work forums, health services forums, and health economics forums. So that is it. So I want to thank you all so much for your attention. I also I know this is going to be archived, so we are including some of websites to resources that we discussed should people have any questions about those. And of course, you're welcome to either ask questions now or directly email me later.
Thank you, Jennifer. Thank you, Megan. Sorry. Thank you, Megan, for that wonderful presentation. And before I turn it over to our commentary speaker, I do want to remind everyone, encourage everyone that you do have questions about the presentation. Please start typing them in the chat box in the lower left-hand corner of your screen, and we'll try to get to them during the Q&A portion of this webinar. So with that, I'd like to turn it over for your commentary, Jennifer.
Sure, and thank you to Megan and to the team and to the University of Kentucky for including me in the discussion today. As the operational partner for this project, the Caregiver Support Program is really thrilled with the partnership that we've established with VA's Health Services Research and Development and the collaboration with Robert Wood Johnson Foundation on this particular effort. Our collaboration efforts with the Veterans Benefit Administration and the feedback from these interviews has really been invaluable in terms of providing us with a variety of rich data that really has helped us to better understand the characteristics of the veteran population we're serving, as well as gain some insights into the benefit services that they're utilizing through VBA. And although the PCAFC is a clinical program that's designed to support the veteran's biopsychosocial recovery and rehabilitation to the extent that's possible, we know that not everyone will transition off this program, but there will certainly be veterans who are absolutely capable of recovery to the extent that they're able to transition back into the workforce in some capacity. And so these veterans may not be capable of transitioning to careers similar to those they previously held in the military, and they may need to explore continued education or new rehab training opportunities to develop new skill sets. Veterans who use the GI Bill are really also addressing quality of life issues that are really closely tied to recovery, such as adjusting to their new place in society or gaining a new sense of purpose, because so many veterans define themselves by their military experience and their training. So this really gives them a new opportunity to reinvent themselves. And it's also really a form of social engagement for veterans who might otherwise be more socially isolated in their social interactions and their relationships. So it's not just about the completion of these degrees or the trainings that are beneficial. It's also participation in the academic environment and all that really comes with that. And so the good news is, that we know that there are veterans out there who are suffering with post-traumatic stress and depression. We know this from the findings from the study, but the good news is really that we can work to help to reduce those stressors and improve academic success through simple things like allowing emotional support dogs, allowing extra time for completing assignments. Post-traumatic stress disorder and depression can be treated, and people can recover from these conditions with the right evidence-based therapies. So some practical things that we can really do. We have a dedicated clinical resource at the medical centers. You've heard Megan talk about our caregiver support coordinators, and many of these are master's level social workers and registered nurses who don't typically address benefits and services that are available through the Veterans Benefits Administration. But certainly these staff members can engage in discussions with veterans and their caregivers about the available resources and benefits not provided by the healthcare system, but more broadly share what might be available and to encourage them to consider all the tools under the broader umbrella that VA makes available to them. So I think we can also consider, working with VBA on fact sheets and flyers and including information to our website and collaborating with VBA on outreach events targeted to our population, and just really ensure that we're sharing information with caregivers who we know who are doing a great job at navigating the healthcare system and just being a source of support for them to also navigate the benefits system. And that really fits into our holistic model of care and the wraparound services that we're trying to provide to our patients. So thank you.
Well, thank you, Jennifer. And so before we open it up to questions from the audience, I do like to take note that Megan's co-investigators on the project, Terry and Courtney, are also on the phone. So if you could unmute your phones. And so we give our project team members, research team members, a chance to respond to the commentary or to add anything more that they would have wanted to add to the presentation too as well. So I turn it back over to you, Megan, Courtney, Terry. You might have to unmute your phones. Sorry.
Okay. Jennifer, thank you so much. I think there's just a lot of alignment between the goals of this project and, some of the holistic models of care and the wraparound support that Jennifer mentioned. And I certainly think that just from the first 6 interviews, some of the emerging themes and the features that we've identified are exactly what Jennifer talked about in terms of information sharing and having the CSCs are already a fountain of information. So just sort of figuring out whether it's, fact sheets from VBAs or sort of what is the medium to use to encourage some of that information sharing. So thank you so much. And, again, thank you. It's been such a privilege for all of us here in Durham to work with you guys. Courtney, did you want to add anything?
No, I don't have anything to add unless there are questions.
I did want to quickly give a little bit of a broader context about the research that we're doing here at the Durham HSR&D because Courtney Van Houten has actually been the PI of an evaluation center called VA Cares that was funded by the Caregiver Support Program and the VA Query to evaluate the initial rollout of PCAFC. And so that research has been ongoing for several years. And this project is sort of an outcropping of that, but there is a lot of kind of existing research and infrastructure here and a strong partnership with the CSP that has really allowed for this project to happen. So I wanted to acknowledge that, and that the team here, we actually have a much larger team within the VA Cares Evaluation Center. So there's several papers out, there's several more that are coming out if folks are interested in learning more about some of the existing research on PCAFC.
All right, thank you, Megan. And so we're going to open the webinar to questions from the audience. We have a lot of time yet, but if you have any questions, please do type them in the lower left-hand corner of the chat box, and if we can't get to them also, we could forward those questions to our presenters today. So I guess to get the ball rolling, Megan, I'll probably start with some of the methods that you did just in regards to the instrumental variable that you use. I know you showed the statistical validity of it, but could you tell maybe a story of how you came about using this as your instrumental variable, sort of just the concept behind why it would have been an appropriate one, and was there other IVs that you were also looking at, in order to instrument your outcome or your treatment, I guess?
Sure.
Yeah.
Sure. Yeah, I mean, this is actually one that we've been looking at for several years and have had an interest in, and because it's at the facility level, it's a really appealing IV because it's not an IV that's based directly on on some characteristic of the individual, and so therefore the relationship between the IV and the outcome at the individual level, it's more likely to be a valid IV because it is a facility level percentage approval. So that was one thing, and there's a lot of variability in facility level percentage too. So that was helpful. It's a continuous variable, so we can make use of that, and also because we decided, as opposed to using it in the current kind of 6-month bucket of the application periods, by using it in the prior 6 months, we also felt that would make it more valid and lessen any impact that it had on the outcome. So this is sort of an opportunity to kind of test that, and it looks like it's coming out well, at least within the it looks like it's coming out pretty well with the post 9/11 GI Bill. Another IV that we had considered was the record number of the individual who actually did the application for PCAFC. So the employee, and Courtney, you may need to just fill in some of the details if I'm not right, if I'm not correct on this, but I believe it was like either the caregiver support coordinator or whatever VA employee processed the application for the dyad. They have a number. And so that we were interested in possibly looking at that examiner's number as an IV, but we haven't, we're still working out some of the details in terms of how to get and process that data. Or we have the data, but how we're going to process it. And so we're not going to use that for this, but that's another IV that we're considering using.
Yeah, so all right, thank you. I wanted to give context. This is Courtney on how the approvals actually happen, that this approval rate, so the idea that what happens at your facility is really determining whether someone gets into the program or not. It's really reflecting practice style because there are multiple numbers of people, but maybe it's only one or two at a different site who is evaluating, at least in the early parts of the program, who gets in and not. So it's kind of trying to reflect this idea that it's a person's or a facility's practice style and how strict they are in interpreting eligibility that may predict someone's treatment, but it's not necessarily their individual characteristics, like Megan had said.
That's interesting, Courtney, because that was going to be my next question. Just looking at the denied and approval rates for the PCAFC, it almost seems that the denial rate is a high proportion. So are you saying it's more of a facility factor, or are there the administrative reasons for denying the PCAFC application? I'm just curious about this, because you're using that to balance your sample.
Right. So there are definitely really clear, concrete eligibility criteria, but individuals are interpreting it, and especially because the program was rolled out so rapidly based on a law, at the beginning they didn't have as many clinical eligibility teams in place, so there was some variation in interpreting eligibility. And in terms of the rate, I think Jen Henius could chime in here because she's an expert in kind of administrative reasons for denials and things like that. But some sites at the beginning were either letting almost no one in or really high approval rates because it was, they were interpreting generously the eligibility criteria. As long as administrative denials were things like you weren't really post 9/11, or because of the law you could only be accepted if you were injured but not ill because of your service. So there were different reasons that would be automatic denials, but otherwise it was based on needing assistance with at least 2 ADLs, activities of daily living, or supervision because of your injury. So and then there were guidelines developed over time too. But maybe Jen, do you have any comments on
No,
variability and okay, good.
That pretty much explains it. Thank you.
All right. Well, thank you for that. So we have right now 2 questions from the audience. One is from Nikita, who asked, what outcomes, you did mention about the subset of younger veterans. So what outcomes are you looking for into the younger veterans with AIM-1?
It's actually going to be the same outcomes. So we're going to perform the same analyses, but just as more of a sensitivity analysis, just look at any changes among younger veterans who may be more likely to use the post 9/11 GI Bill, and and supported employment. Yeah, so same outcomes as the big study.
Okay. And our last question from the audience is from Anna, who says, you discuss veteran frustrations and anxieties. To what extent, if any, are qualitative analysis examining caregiver frustrations and anxieties, the management of which would seem to be a critical component for both program effectiveness and sustainability?
And I can talk to a little bit of the research that's going on here in the VA Cares Evaluation Center. Certainly, in the interviews that we're doing for this study, we are seeing, veteran frustrations and anxieties and caregiver frustrations and anxieties are both coming up. We are also in the process of doing a longitudinal survey that's being funded by the Caregiver Support Program. That it's a survey, but it's directly asking questions about like the Zaret burden scale and both emotional and physical health issues of the caregivers. These are older caregivers, so these are caregivers that right now are in the general program, and so we're getting to a lot of that. There was a qualitative analysis that we did on the use and value of PCAFC, and a little bit came out, though that was not focused directly on caregiver frustrations and anxieties. So we're doing a little bit of this. We haven't done a direct qualitative study, though, on caregiver frustrations and anxieties. And Jen and Courtney, I don't know if there's anything else going on that you know of that might address this point.
No, this is Jennifer, not in terms of any studies, but certainly as part of the eligibility process, we are meeting with caregivers and we're doing a comprehensive assessment, and we're coming up with a plan to get them access to the resources they need, including mental health care, because they're eligible for mental health care if they wanted to seek out supportive services. And then we have a number of psychoed education and classes, support groups, and things like that they can reach out to learn new coping skills and get other sources of support. We have a peer support program where caregivers are being mentored by other caregivers. So that's another place where caregivers can get support. And then someone had mentioned, I think Megan, you had mentioned the Zaret burden screen, and we do that as part of our eligibility assessment as well. So I don't think, like you mentioned, we don't have any specific survey, but we are trying to meet caregivers where they are and provide interventions where we can.
All right. Well, if there are no more questions from the audience, I guess maybe to tease where you are in terms of the next steps, Any preliminary sort of teasers out there for what you're looking at in terms of voc rehab and support employment outcomes? Are you sort of started to see some trends or something that you can share probably, or you're trying to first save that for future presentations?
Well, so not actually from the quantitative. We have all the cohorts defined, and we haven't run those models yet, though that's in the works for the next week. I can tell you, because I've been doing the quantitative, but also doing some of the interviews as well, and it's been interesting because the post 9/11 GI Bill seems to be the easiest service for folks to engage in and apply for. And while there hasn't been a huge success rate of completing school among our participants, people seem to get farther along than they have with the other two services, which I think is really interesting to think about the differences. Another sort of interesting thing that we want to look at is, does being in, are folks sort of less inclined to sort of finish some of these services because they might worry that once they're working, there might be a change in their disability status. So there's some perverse incentives at play that, could be really interesting to tease out, then to figure out what to do about those, right? So that, there's not this kind of this clash of incentives. But it's been, I think caregivers play a huge role. It's not a surprise to anybody, but really understanding the tasks that they play and how to support them in those tasks, I think is really coming out, and I'm optimistic that, we'll have a lot of concrete ideas about how to support them in this way.
Excellent. So that we'll be really looking forward for that. And I just wanted to remind everyone that research for Megan and her team and the ongoing progress of that would be also available on Systems for Action website too, on their project page. So with that, Megan and your team, Terry, Courtney, we thank you so much. And Jennifer, thank you so much for your commentary and your time today. We do want to remind everyone, I invite everyone to that today's webinar is available for download from our archives. The System for Action it will be ready for download. And we'd also invite everyone to take a look at our upcoming webinars and hope to see you there too as well. So with that, I wish everyone a good day and thank you so much for joining us, and we hope to see you next time. Thank you so much.